Welcome back, everybody, and I'm excited to share this fourth and final episode regarding the foundations of hospital revenue cycle and the reimbursement methods that we have of obtaining reimbursement for patients in inpatient acute care setting. So thank you, and let's continue this conversation. Thank you. Hi, all. This is a disclaimer statement I have for every conversation we have. Every effort has been taken by the author of this presentation to ensure that the information shared was current as possible at the time it was developed and presented. The primary intent of this presentation is to be informational only and to share this information in a manner that is more relatable and understandable to those in healthcare with various backgrounds and levels of experience. The information shared is only intended to be informational and not take precedence over any state, local, federal guidelines, organizational policies, or procedures. Again, this is just a review of the documentation, reimbursement, and medical necessity that is obtained from the attendee provider's documentation. The establishment of the primary working diagnosis, along with the capture of the complicated and comorbid conditions and the major complicated comorbid conditions and any procedures performed, affect the assignment to the medical severity DRG. Also, just as important are the capture of the secondary or other diagnoses, which are those conditions that may coexist at the time of the admission that develop subsequently or that affect the treatment received and or length of stay. These conditions are being clinically evaluated with diagnostic tests and or other modalities within the context of working up the patient for another diagnosis or condition. Undergoing therapeutic treatment that may be receiving care that necessitates an increase in nursing care hours and subsequent monitoring. These may qualify as complicated conditions or major complicated conditions, which are known as CCs or MCCs. These elements, documented by the attending provider, really speak to the complexity of the patient and the increases in resources that the hospital is expending to care for this patient. So once again, we're just going to review some terminology that we've used in other videos. MSDRG, it has a unique relative weight assigned to each MSDRG. It is assigned, the assignment of that MSG is based upon procedures, principal diagnosis, secondary diagnosis, and all other conditions that the patient is being monitored, treated, worked up for, that the extent and length of stay require more resources are being evaluated or worked up. There is another payment system called the APDRG, which is all patient refined diagnosis related grouping that is used by non-Medicare payer sources. It consists of establishment of the procedure, principal diagnosis, secondary diagnosis, all other conditions the patient is being monitored, treated, evaluated, or worked up for. Specific to this system is the assignment of patients into a severity of illness category and risk of mortality category. Each of these two categories, severity of illness and risk of mortality, contain 4 groups ranging from minor classification 1, moderate classification 2, major classification 3, and extreme classification 4. And reminder that the payment for the hospital has a formula of relative weight times hospital base rate. Resource intensity is the relative amount of type of diagnostic and therapeutic and bed services used to manage a particular disease. And then I'm also going to walk you through the severity of illness classification that is used for the assignment of APDRG. So we'll take an example of a patient with a cold. That is classification of 1, which is severity illness is minor and a cold is minor. Classification 2, moderate severity of illness, is a patient with moderate bacterial or viral pneumonia. Classification 3, which is major severity of illness, is the classification of severe patient has severe bacterial or viral pneumonia. Mind you, this is severe. Extreme is somebody with stage 4 lung cancer. So again, it addresses the level of 1 through 4, 1 being the least severe to 4 being the most severe. So this is just an example. So let's go into the discussion of ROM, or risk of mortality, which is the likelihood of dying or risk of mortality associated with this condition. So for instance, classification 1, minor, would be a patient with premature beats, and this is for cardiac dysrhythmia. Classification 2, moderate risk of mortality, would be having a sinoatrial node dysfunction. Classification 3, major risk of mortality, would be paroxysmal ventricular tachycardia. Classification 4, which is extreme, ventricular fibrillation. Okay, so you can see how the classifications truly reflect the disease process and the risk of mortality. And again, we're going to review the term case mix index because this is something that's commonly used that you may hear, and I realize it's not part of everybody's clinical language because it certainly was not mine before I traveled over to this side of the world of hospital care. Case mix index, again, is the average of the relative weight, DRG weight. And remember, each DRG has a unique relative weight assigned to it. So the case mix index is the average relative weight for a population of inpatient discharges. It's calculated by summing up the total of the relative weights of the MSDRG for each inpatient discharge, and then it's divided by the sum of the total number of discharges. The higher the case mix index value is indicative of the increased resource complexity of that patient group and reflects increases in resources and need for that group of patients by the hospital to care for them. It's an indicator of how sick this group of patients is. So this is just an example. I always do better when I see something that's written out that really tells me what we're looking at. So for instance, a DRG, which is a group of patients with cardiac arrest with unexplained with an MCC, a major complicating or comorbid condition. That DRG has a relative weight assignment of 1.6383 with 236 discharges. So the relative weight of 1.6383 times 236 gives a total relative weight for that 236 patients of a total of 386.64. And that is done, that formula is carried out for these 4 DRGs. And the total number of discharges down at the bottom in red is 768. And the total of the relative weights for all those 4 groups that represents all those discharges is 949.7608. So the case mix index is the total of the relative weights, 949.7608, divided by the number of discharges, 768, gives me a case mix index of 1.237, which is again an indicator of how sick this group of patients are. So there's several factors that affect the CMI. High incidence of short stay inpatients, because if there's not medical necessity there to support the inpatient status, then they're discharged. Volumes of surgical versus medical cases. Surgical cases have higher CMI. Inaccurate documentation in terms of the documentation not being quality, in terms of being concise and clear and detailed to allow coding to the highest specificity, which again would optimize the case mix index. The case mix index too low is sometimes reflective of the resource intensity need for the group not being accurately reflected in the DRG assignment. So they're assigned to a lower DRG, which means that there is inadequate code assignment and payment. So not accurately capturing the severity of illness required for the correct DRG assignment, and the payment received for that group of patients will not cover the dollars spent for the resources used by the hospital to care for that group of patients. Again, I'm just going to show you a brief example at the bottom of the slide where you're able to see how a hospital payment is calculated. So let's say there's an MSDRG assignment of $195 for simple pneumonia with pleurisy and without a complicating condition or major complicating condition has a relative weight of 0.6418, and the number of discharges for this patient population is 154. Let's just say for 1 month on a med-surg unit. That's a pretty common diagnosis. Gives a total relative weight of 98.8372. And so that relative weight of 0.6418 times a hospital-based payment rate that I picked out of the blue of $5,000 equals $3,209.00 for the payment of one of those patients. So again, one patient account has an MSDRG of 195 for simple pneumonia, and the hospital-based payment rate is 5,000. So we take the relative weight times the hospital-based payment rate, and that patient we're going to get reimbursed at $3,209 for this patient, regardless of if they stayed shorter than the geometric length of stay or if they stayed longer than the geometric length of stay, regardless of what resources were used to take care of the patient. This is what we get paid. Documenting precisely provides for continuity of care. It justifies medical necessity and allows for the capture of all conditions being monitored, treated, evaluated, worked up, leading to an increased length of stay or are requiring more monitoring. These are all the benefits of a healthy operating budget for our patients. More services, training, ventilators, meds, the list is endless. If there's no money, there is no mission and no place to carry out the mission of caring for patients. This is a partial list of the resources that I've used, and so I hope they've really added to the discussion. This is the second page and last page of resources I've used, and I've hoped that this has really led to this discussion of the foundations of healthcare, and that we all have a better understanding of the terms, concepts, and ideas. I appreciate the time and the energy that is taken for all of you to sit down and participate in this discussion. My email is there if you have other topics that would like to be covered. I thank you all again, and the next series of videos will go into disease-specific opportunities for documentation such as diabetes, heart failure, pneumonia. So thank you all again, and I really appreciate hearing from all of you and having this discussion that I think is so needed, as we all need to collaborate and work together to keep the doors of the hospital open, because I know that we all as health professionals are on one team that share the common goal of providing care to the patients in need of it. Thank you all.